Welcome, everyone. Thanks for being here today. Today is one of our special grand rounds of the year. This is our fifth annual Kevin Graham Lecture. Kevin Graham started the prevention program here at MHI roughly 20 years ago. And that was obviously a time where the business model was not very favorable for prevention. The better job he did, the more he put us out of business. But yet he had the vision that was the right thing to do at the time, it's the right thing for our patients. And so our first speaker for the Kevin Graham Lecture was Phil Greenland, an expert in cardiovascular epidemiology. Our second speaker was Dari Mozafarian, one of the global experts in nutrition. Our third speaker was Roger Blumenthal, who's one of the founders and the pioneers in cardiovascular prevention. And then last year, our fourth speaker was Seth Katharizan, who's working on genetic editing to reduce cholesterol and cardiovascular risk. And so obviously for this lecture, the bar's been set pretty high, but I think today's speaker will keep it high as well. And so very excited to welcome Dr. Martha Gulati as our speaker for the fifth annual Kevin Graham Lecture. She grew up in Canada and did med school at the University of Toronto. She trained at residency and fellowship at the University of Chicago. She was recently the chair of cardiology at the University of Arizona, and then has transitioned to be professor of cardiology at the Schmidt Heart Institute at Cedars-Sinai in Los Angeles. She is a director of the prevention program there, and also co-chair of the Barbara Streisand Women's Heart Center there. She has thrived in various leadership roles. She was recently the chair of the 2021 ACC-AHA chest pain guidelines, and she's also currently the president of the American Society of Preventive Cardiology. So we're very excited to have her here. Please help me welcome her. And she's going to talk today about women and cardiovascular disease. Is there really a sex difference? Dr. Gulati.
Well, thank you for having me here. It's such an honor to be giving the Graham Lecture. Usually when I come north, I feel comfortable that I could talk hockey, but then the Maple Leafs just made it embarrassing again. So I have nothing to talk to you about hockey, but I do want to talk to you today about if there are sex differences in heart disease. And so I'm going to go through quite a few things, and I'm going to try to convince you that yes, there's sex differences, but there's also a lot of differences that aren't based on sex. They're gender differences, how we're seen by society. And so I want you to just think about the things that I show you to decide for yourself if you think it's sex or do you think it's gender. And often some of the differences in outcomes and treatment are actually based on more gender rather than sex. So here's my disclosures. Nothing that I am on is going to be related to my discussion here today. But I think we're going to start with, who has traditionally been known as the other sex, and that's, Simone de Beauvoir actually labeled us as the other sex with the point that we've always been compared to men. We're always, they're first and then we're second. And the point is that women are not small men. And as I said, there's differences particularly related to cardiovascular disease due to gender. There's also differences due to biological sex. And I'm going to leave you at the end with asking you the question about, where are the women related to research? Because there's obviously been a lack of inclusion of women, particularly in cardiovascular research. Our conversation, though, really starts with the beginnings. And the beginnings, many, many years ago when I was in medical school, and Dr. Nanette Wanger, who we consider the mother of women and heart disease, she actually said this, that we've really taken a bikini approach to women's health. She said, the medical community had viewed women's health with a bikini approach, essentially looking at the breast and the reproductive system and ignoring the rest of a woman when we talk about women's health. She said that more than 2 decades ago, but yet still, even after she has said it, I've written a number of editorials asking the same thing, asking her question, when do we plan to move beyond the bikini and protect a woman's heart? Because we see so many disparities in our care, in our research, and so that's what our focus is going to be on. We know cardiovascular disease is rising in the United States, and that's true both for men and women. In the last decade, actually, where all the strides that we have made, we seem to have lost. And it seems to be particularly in our younger people. Younger people are dying of heart disease at rates greater than they ever did before. So we have a lot of work to do, but there was a time in the 80s where we were making dramatic reductions in mortality due to cardiovascular disease. There's such an explosion of treatments, and the way that we approach cardiovascular disease became very evidence-based. But we applied those guidelines, those recommendations, more to men than we did to women. And it wasn't really until 2001 where we started seeing reductions in mortality due to cardiovascular disease in women. But again, now we're going backwards. So of the 1.3 million deaths in the United States, over 400,000 of them are due to cardiovascular disease, of course, making that the leading killer of women. The second leading cause of death in women is chronic lung disease, just over 80,000 deaths. Lung cancer is the third leading cause of death, and the fourth leading cause of death is breast cancer, accounting for 42,000 deaths in the United States. So a tenfold greater risk of dying for cardiovascular disease. But when we think about what our female patients actually understand or what they worry about, we know women worry about breast cancer far more than they worry about heart disease. And even when they go to the physician, what does the focus become? Did you get your mammogram? What else do you need? We don't really always get cardiovascular screening or testing for women in the same way that we think about it for men. And even in terms of prevalence, there's about 60 million women in the United States living with some form of cardiovascular disease compared to 4 million women living with breast cancer. Again, it isn't to belittle the risk of breast cancer, it's very real, but to just put it in perspective for what we need to communicate better to our female patients. So every day it feels like, at least it feels like to me, when we read, whether it's during Heart Month or, and we do get the shortest month of the year to bring attention to women and heart disease, but again, that is the month that often there's papers written about women and cardiovascular disease. And it seems like every year we'll have some study say, women aren't doing as well. Women have a higher mortality rate. And this is just one example. This was an international survey, the Isaac Archive study that looked at a large number of men and women after acute coronary syndrome and said, particularly after STEMI, women have a higher mortality rate compared to men. And every day there's a study that it feels like that comes out and shows, yes, there's a sex difference. Women do worse. And, we even have a recent analysis of the Virgo study, which is a study of young men and young women under the age of 55, all who have had an acute myocardial infarction. And they just did a recent analysis showing even as they follow these patients out, young women who have an acute MI have worse outcomes the year after discharge, particularly related to coronary hospitalizations, but also non-cardiac hospitalization. So we continue to have this, but we don't necessarily figure out how to change this. So year after year, we keep saying this, but we're not making strides in this improvement. And so, like I said, I'm going to talk about both sex and gender. And I want you to ask yourself, is it a biological difference being XX versus XY? Is that what's driving the difference? Or is it gender? Is it the social construct, how we are seen by society, that is driving these differences? If it's biologic, remember every cell has a sex. Therefore, every gene and every molecule is influenced by our biological sex. That affects obviously our hormonal status, our ability to get pregnant. There's a lot of things that are determined by our biological sex. But gender, you can't tear that fully away either. How we're seen by society, how people approach us, that affects our employment, our access to care, whether our symptoms are taken as seriously. So these are all things that are intertwined into whether people get the same care. So I'm going to use a lot of examples of acute coronary syndrome, acute myocardial infarction, because that's where, obviously, in our cardiology world, that we collect the most data, right? We're always trying to say, are we improving the care? This is where we have national databases and international databases that help us really move the needle. I mean, when we think about door-to-balloon times, how that all changed the cardiovascular care, those numbers, even the public started understanding what that meant. So I'm going to use that as an example just to show differences between men and women. So in an acute myocardial infarction, particularly ST elevation myocardial infarction, we know that women who present with an ST elevation myocardial infarction are treated less aggressively. And particularly if we look at very quantifiable data like door to balloon time, we know it's longer for women than it is for men. We know that in general, women are less likely to be taken to a cath lab, even with an acute myocardial infarction compared with men. And in places that still use thrombolytics or only can use thrombolytics, we know even there, their door to needle time is also longer in women compared to men. When we look at medications when people experience acute myocardial infarction, the guideline-directed medical therapies that everyone should receive after an acute myocardial infarction, we know that whether you look at 24 hours after the event or even upon discharge, women are less likely to receive guideline-directed medical therapy compared with men. And as a result of that and many other factors, women are more likely to have readmissions after an acute myocardial infarction compared with men. And also, women are more likely to die, particularly with the ST elevation myocardial infarction group. And particularly in our younger women, women under the age of 55 actually have the highest mortality rate after an acute myocardial infarction than any other group. And we also know this isn't a unique problem to the United States. So, this is a global problem. We just recently did an analysis, that's the last reference on this slide, but we took all the countries and just looked who has data on sex, and really the only continent that we couldn't find good data on men versus women was in the African continent. But anywhere else that has collected that data, they show the exact same thing. So it's not unique to our country, it's just really a problem globally. Just to show you some reasons why these things are happening. Just even our approach to women who experience chest pain. We know women will experience less timely care. This is from the National Hospital Ambulatory Medical Care Survey from 2014 to 2018. And this represents 29 million emergency department visits. And they just looked at young people, so young adults under the age of 55, who presented to the emergency department with chest pain. And what they found is that women who presented to the emergency room with chest pain, again, we're not saying that their symptoms differed, we're just saying they had to say chest pain. Women were less likely to be triaged as an emergent case. They waited on average about 10 minutes longer to be evaluated compared with men. They were less likely, though, to receive an EKG or put on cardiac monitoring. They were less likely to be seen by a cardiologist, and they were less likely to be admitted to the hospital or to an observation unit. And they also saw similar findings in people of color. So anytime I talk about women, you can almost substitute people of color in many of these places. But again, if we don't even approach chest pain in the same way in women as we would with men, then it starts there, right? Because that's such a common symptom. We know even our preventative care, so how we approach people once they have a diagnosis, is not as good in women compared to men. In this study, they looked at over 600,000 patients who had a diagnosis of atherosclerotic cardiovascular disease. And they asked a very simple question, because if you have ASCVD, you should be on a statin, and you should be on a high-intensity statin. So they just asked, are people getting a statin if they already have a diagnosis of cardiovascular disease? Well, we don't do good with our statin therapy, as everyone knows. Over half the patients were not on any statin therapy, and only about a quarter of them were on high-intensity statin therapy. But the odds of getting a high-intensity statin were greater if you were a man than if you were a woman. So that's at least one example. There's many other examples. There's, of course, studies looking at young women, because, of course, we're focused on the younger people, trying to figure out why that gap is why younger people, and particularly younger women, have such terrible outcomes. And we know after acute myocardial infarction, young women are less likely to receive non-aspirin antiplatelet agents, lipid-lowering therapies, or beta blocker therapies compared with men. So again, we shouldn't be surprised by our worse outcomes. And then you can see here that from the TRIUMPH study, they looked at rehospitalization a year after acute myocardial infarction. And you can see that within the first month after discharge, these lines start separating. Women are in the gray bars and men are in the black bars. And the younger women and men are shown by the solid lines compared to those over the age of 55 are the broken lines. And you can see that, again, women in the first month, but also out to the first year, particularly younger women, are more likely to be rehospitalized compared with men. Now, it's less so for those who are older, but still there is a difference. And what's also true is that the sickest women who present with acute myocardial infarction have the worst outcomes of all. So when people present with ST elevation myocardial infarction who are in cardiogenic shock, of course, that is our sickest group. You know, we have to pull out everything to try to save those lives. We know many of them are going to die. But when we looked in the national inpatient sample, here you can see from 2006 to 2015, they looked at all ST elevation myocardial infarction who presented with cardiogenic shock. And they found that women were treated less aggressively. They were less likely to undergo invasive coronary procedures like revascularization, but also mechanical circulatory support. They were less likely than men to undergo a right heart catheterization. And as a result, women were more likely to die. So much higher mortality rates in women compared to men. There's also some racial differences as well. So again, when the people are the sickest, we should really be pulling out everything. And, you know, like I told you, it seems like every day there's another paper saying women do less well. And I think if I get asked anymore to write an editorial after yet another study, I start becoming very creative in my titles. We literally called this editorial Adding Insult to Infarct because we're basically insulted that we keep being asked to write the same thing without solving the problem. You know, we want to really find solutions. And so we really focused our editorial not so much at what the study showed, because this just seems to be a recurring theme, but what do we do to really narrow the gap? How do we really change this? What is the way forward? And I think that's where we really need to be focused now, is really how do we actually change things? Rather than just talking about, yes, women are less likely to get guideline-directed therapy, they're less likely to go to cardiac rehab, they have a higher mortality and higher rehospitalization, they have poor quality of life. And you know, we can use acute myocardial infarction. Like I said, it's a very public database, so it's a way to actually show what's going on. But we can look at other diseases too and show differences. And so this study is a study of heart failure, looking at the Veterans Hospital. And so the Veterans Hospitals are always the VA hospitals are quite interesting because, you know, every prescription can be followed. Every prescription written and every prescription filled is known. And so they looked at patients with incident heart failure, meaning they were just diagnosed with heart failure. And they, again, asked a very simple question. They said, if you have heart failure, did you at least get one of the guideline-directed medical therapies? They didn't even say all 4 pillars, just one. And you can see we don't do very well. And you know, they looked at 30 days and then 90 days and then 12 months after the diagnosis. And of course, over time, the use of at least one guideline-directed therapy was increased. But you can see, again, 22% versus 37% in men. And then out to 12 months, it improves to 40% in women compared to 62% of men getting on at least one guideline-directed medical therapy. So again, there's gaps in how we approach even heart failure. Now, admittedly, you'll say those numbers are really small, and they are, because there's not many VA veteran women yet. I mean, there's increasing numbers, and so we'll learn more as we continue to follow the VA population as that demographic is changing. But it's certainly interesting that we'll treat people differently. And we can look at other areas of cardiology to see these differences as well. Think about TAVR. The early TAVR trials, like the partner trials, showed that women did better with TAVR than men, actually. And we know with surgical aortic valve replacement, women did not do as well as men. So finally, we have this treatment that women can do actually at least as well as men, if not better. And yet we don't offer it to women as frequently as we do men. That's what our national data shows, is that we are still lagging at our referrals of women who ultimately require TAVR. You can think about atrial fibrillation, something we all see every day. Atrial fibrillation, women are less likely to receive adequate anticoagulation compared with men. We're less likely to offer rhythm control strategies, including ablation, to women compared to men. And again, women tend to be more symptomatic when they remain in atrial fibrillation compared with men. And yet we don't offer our advanced therapies as frequently to women. ICD use as well, and particularly CRT. You know, if you think of the early MADIT trials, the CRT was actually more beneficial to women than men. And yet, when we look at our real-life utilization of CRT, we know we don't do great referring these patients anyway, but women are less likely to be referred than men, even those who meet criteria for CRT use. And think about it, heart transplant. Women only represent a quarter of LVADs and only a quarter of the heart transplants here in the United States. And we see, again, these trends nationally, internationally as well. So some of you might be saying, well, you know, maybe at least some of those delays in care, particularly related to acute myocardial infarction, are because women present differently than men. And so my question to you is that true? Do they really present differently or not? And again, we're going to go back to acute coronary syndrome and ischemia just to really, again, try to tease that out. You know, because with acute myocardial infarction, we often had been giving the public health message that women present differently. And yes, there are differences between men and women, but there are also many similarities. Think about younger women and men, because that again is a group that we're still trying to figure out why there's such a gap in care. But the Virgo study was able to look at that. The Virgo study, again, just to remind you, was a study of young men and young women under the age of 55. We really didn't know until Virgo, really the younger people, what were their symptoms? What did they experience? Well, the Virgo study collected that information, and they actually found that in terms of symptoms of chest pain, 90% of women and 90% of men reported chest pain. So it wasn't that they don't say chest pain. The difference, though, between women compared to men was this. Women were more likely to report 3 or more additional symptoms, whereas men seem to just say, you know, have one symptom or maybe a second symptom, but not as descriptive as best the Virgo trial could show us. What was interesting about the Virgo trial, too, was they actually asked both the men and women, did they seek out care prior to that cardiac event? Because they had all had a myocardial infarction by that point. And of course, there was actually more women that sought out care before their actual event. But women were much more likely than men to be told that their symptoms were not cardiac in nature. So that's at least what we know for younger people. Now, the high stakes group is the group that brought us the high sensitivity cardiac troponins from the UK. And they were able to collect symptoms as well. And I'm sure many of you have seen this paper from 2019. They actually showed this bullseye diagram, red being women and blue being men. And they arranged the symptoms that people described as typical or atypical. And they showed actually more women had the typical symptoms. Again, they showed that women had more additional symptoms along with these typical symptoms. But this sort of idea that women were somehow presenting atypically was not found. And there's a study called the Hermes study. They used a very interesting form of AI. They used cardiolinguistic technology. Basically, they listened into the conversation. It was a computer that recorded if it heard any words, and particularly chest pain, but anything that was said between the physician and the patient was recorded and analyzed. And what they found is that, again, 90% of women and 90% of men did report chest pain. Again, women were more likely to have other symptoms and, again, things that we would consider quote unquote atypical, but chest pain was present. And so this idea that women don't experience chest pain, I think that that's a wrong message that I think we need to change. And we tried to change it in the chest pain guidelines. So some of our recommendations in our chest pain guidelines that you might have seen is we said, atypical, don't use that word anymore. Atypical, whenever my fellows say that somebody has atypical chest pain, they used to mean that this person does not have, this isn't cardiac, don't run, don't worry about this patient because I don't think it's cardiac. And so that's often been, made our approach be less intensive. And it also doesn't really tell us what's going on. What is atypical about it? How is somebody presenting differently? So we actually said one of our class 1 recommendations is that chest pain should not be described as atypical because it isn't helpful in determining the cause. And we said that chest pain should actually be described in a different way. Cardiac if you think it's cardiac, non-cardiac when you think it's non-cardiac, and possibly cardiac when you don't know. This at least will be more specific to the potential underlying diagnosis and also might help us recognize why we're doing certain testing once we decide when we don't know, maybe it is cardiac. Again, the idea that this might actually improve our care. The other thing that we said in the chest pain guidelines that may be very obvious to this group, but not always so obvious to our ER colleagues, is that, we wanted women to be recognized to be at risk for heart disease. And so we gave a class 1 recommendation to understand that women who present with chest pain are at risk for underdiagnosis and potential cardiac causes should always be considered, just like we do for men. And that this idea that women often present with other accompanying symptoms, are we not listening to our patients? Are we just not hearing chest pain? Is chest pain there? Maybe we'll get better if we start really looking at our patients and listening to them well. And hopefully these recommendations will help us narrow some of the gaps because again, as the cardiology community, we can't come if we're not called, right? Like we need to be called before we can do anything. And so in terms of some of the gaps in care, remember the chest pain guidelines were written both for our cardiology community, but also we had many ER physicians on our guidelines as well. And it was to really the whole spectrum of chest pain that is experienced that we want to ensure appropriate care happens. Well, what about the sex differences in cardiovascular disease? Because most of the things I've talked to you about, I hope that I've convinced you those are really gender-based. Those are based on being seen as a woman, that we treat you differently. But there are sex differences in cardiovascular disease. And we, of course, had hints of this even in the early days of, like the Gusto trial. They actually, to meet the criteria for STEMI or non-STEMI or unstable angina, were very strict. But even there, they saw that many people, despite meeting the criteria, had non-obstructive coronary disease or quote unquote normal coronary arteries. And it was much more frequently seen in women than in men. And more often seen, obviously, in those with unstable angina compared to the MI group. Even think about the recent ischemia trial, where you had to have moderate to severe ischemia to get into that trial. And yet even there, 14% of patients had no obstructive coronary disease. So non-obstructive coronary disease is one place where there's an example of sex differences because it occurs more frequently in women. And some of our work showed for the first time, this is an older paper, but for non-obstructive coronary disease, which is also known as ANOCA, ischemia with no obstructive coronary arteries. We actually took the WISE study, the Women Ischemic Syndrome Evaluation Study, and we compared them to age and race matched women, a cohort of women that I had in the Chicagoland area that were normal, asymptomatic women, and we demonstrated that the people who were symptomatic and had signs of ischemia, despite not having obstructive coronary disease, had higher rates of future cardiovascular events, as you can see here. They're the black bar is the Y study, and then the asymptomatic women are the white bar. And so we were one of the first groups to demonstrate that, but subsequently there's been a number of studies showing that ANOCA is not a benign disorder. And we know that obstructive coronary disease is only one part of really ischemia. Although when I remember very distinctly, both in residency and fellowship, that we were taught that you couldn't have ischemia without an obstructive lesion. And I remember many patients who didn't have an obstructive lesion being told, oh, well, we don't know why your troponins were elevated, but it's a false positive, there's nothing, we don't know what it is due to, and it was much more frequently seen in women. Now we're getting a greater understanding of non-obstructive coronary disease and microvascular dysfunction. Again, disproportionately affects women compared to men. I will admit that we don't yet to this day know how best to treat ANOCA, but we do have the ongoing Warrior trial that we're just closing up. Actually, this is our last month of collecting data, and later this year we're hoping at AHA to present the results of our study that hopefully will help guide us on how to best treat these patients. But really, just this understanding of ischemic coronary disease has become important. And of course, there's a lot of things that are going on, but it's very relevant to our clinical practice because there's a lot of, this affects both men and women, again, women disproportionately, but it does result in high healthcare costs because people with non-obstructive coronary disease get rehospitalized again and again in our hospitals with chest pain often or with symptoms of ischemia. And the question of repeating studies often comes into play. So hopefully with our study, from the Warrior study, we will learn more about how best to treat these patients. But hopefully both for ANOCA and MINOCA, rather than what I learned when I was training, was that, hey, it wasn't a heart attack after all, you had normal coronaries, maybe we'll change that message in the future. Now, Takotsubo syndrome is something that disproportionately affects women. Takotsubo is also known as broken heart syndrome, also known as stress cardiomyopathy. Again, the 90% of the people that are affected by this are women. And again, for postmenopausal women, it now accounts for about 10% of all acute chest pain. And of course, presents as acute myocardial infarction that we later make this diagnosis. It is not benign, even though in the early days of describing Takotsubo's, people thought this was a benign disorder. We know there's about a 5% in-hospital mortality with Takotsubo syndrome. And we know that actually about a 20% of them who experience Takotsubo's are left with persistent abnormalities in their left ventricular function. And even those who survive have a higher incidence of major adverse cardiovascular events and mortality. We know about 10% of the patients actually experience recurrent events, and we don't know how to predict who's more likely to have a recurrent event of Takotsubo's versus who is not. We also don't know how to treat a recurrence or Takotsubo's, to be honest. So we don't really have any established therapy. And again, this is a female predominant disorder, so of course we're a little bit lagging in understanding this condition. But I know there's more work going on in this area now with many registries trying to collect this data and figure out how best to deal with this. But I think at one point we thought it was rare, and then now we realize it's really not rare. What about cardiovascular disease risk factors? Since I am a preventive cardiologist, I think the way to really deal with a lot of this is how can we prevent disease up front? Well, even in our traditional risk factors, there's sex differences. If we think about even diabetes, women who have diabetes have a greater risk of developing cardiovascular disease compared to men who have diabetes. We've known that for many years. And so why is that? Hypertension, something we deal with every day. We have some work out of a colleague of mine at Cedars, Susan Cheng. She's shown that, blood pressure trajectories, it's not that blood pressure just increases at menopause. Actually, women throughout their lifetime, we just have a higher trajectory despite starting at a lower systolic blood pressure. Our rate of increase is actually higher in women. What makes it that we should have the same thresholds for women versus men. We've just always done that. But there is some data to support, and we need more research in this area, but perhaps one day we'll actually have sex-specific thresholds. Because if we've been living at lower blood pressures, what makes it okay for us to have higher blood pressure values later on in life? And it isn't something, that just turns on during menopause. It's something that actually is happening throughout our lifetime. Even think about lipids. I mean, there's usually not very many differences by sex in lipids, but Lp(a) is one exception. Now that we have more focus about Lp(a), we know that women, as they go through menopause, again, Lp(a) can change despite it being pretty consistent throughout life in men. So that is something that's a little bit interesting. Tobacco use. We know if women smoke the same number of cigarettes as a man, again, the vascular damage is greater for women compared to men. And I'll show you some data about exercise that is different between men and women related to some of the work I've done, but even diseases of inflammation that are associated with heart disease, rheumatoid arthritis, lupus, and other disorders, we know are much more common in women than men. Women have more inflammation, and their association with cardiovascular disease is greater. So there's a lot of even our traditional risk factors that we need to think about. And then there is sex-specific risk factors as well. I promised you a little bit about exercise, since that's an area of work that I focused on. This is from, again, that cohort of women. We had 6,000 women in the Chicagoland area that I studied. And, we put them, they were all asymptomatic women, and we put them on a treadmill to find out about, their functional capacity. And we created the nomogram, or the first equation, to give really the sex-specific fitness level for women. Before that, we only had the male fitness level described. It was all studied. They admitted it was studied in men, and they just didn't have women, but we used that equation to say this is where everyone's fitness level is. And then we actually showed, no, they're not the same. Nobody expected them to be the same, but nobody had looked at them. And then we created this nomogram. This was published in the New England Journal of Medicine. And, we showed and validated it in symptomatic women to show not only what its prognostic ability would be, both for death from cardiac causes and death from any cause. Similarly, we use that cohort of women to describe heart rate for women. So, 220 minus your age, the most used equation every day by the lay public and the medical community. If you ever have time, go back to that original paper and see what a terrible paper it was. They just used 5 different studies of young, fit men that were Army-based men, and they never thought that that paper was going to be the paper that everyone looked at and used day to day. Every smartwatch has 220 minus your age, calculating your 100% of your age predicted heart rate. Anyway, we showed in our 6,000 women, each one of those dots is one of my 6,000 women. We showed that for women, the equation was different, 206 minus 0.88 times your age. So not a fancy, easy equation by any means, but still, we can program things these days to really help us do these calculations. We validated it again. We showed it compared to the traditional estimate. And really, we can use these measures to really better, when we study women, use the equation that works for women. And just recently, you may have seen that we had a paper that just came out about physical activity, since not everybody goes on a treadmill for us, but physical activity, self-reported physical activity. We have over 400,000 patients in the United States from the CDC database where they've collected physical activity, and we're able to link this to all-cause mortality and cardiovascular mortality. What we found is that, anytime there's a recommendation that's the same for men and women, we should always question, where did it come from? Even when we say 150 minutes of moderate physical activity is good for everyone, where does that come from? I'm not entirely sure, but what we showed in this study is that men get the greatest benefit doing 300 minutes per week of physical activity, of moderate physical activity, and women get the same mortality benefit of doing almost half of that, 140 minutes a week. So finally, some good news. Women get more out of exercise than men. Even resistance training and weightlifting, you can see that men get the greatest benefit at doing 3 sessions a week, and women get the same benefit just doing resistance training once a week. Now, if women did 3 times a week, or if women did 300 minutes of aerobic activity a week, they actually also, that was their peak benefit in terms of mortality, but it was associated with a greater reduction in mortality. So again, for once, good news. Women do need to exercise, of course, and I'm not saying that we necessarily have enough data to change the recommendation, even though the recommendation seems to be pulled from the air, but I do think that for our patients, if we say, you do something rather than nothing, and you get more, women unfortunately get more out of every minute of exercise. For once, we have some good news. And again, this is just sort of a summary slide of what our findings that was published in JACC just a few weeks ago. In terms of our prevention, though, when we think about how we approach prevention, whether you use the ASCVD risk calculator, we plug in the numbers, and the thing for women is just if you're male or female. Now we have the new Prevent risk calculator. The difference is they've taken out race, they've added in chronic kidney disease, and they've also put in social determinants of health using your zip code, which may be helpful. But again, in terms of anything sex specific, it's just whether you're male or female, put that in. Of course, we use risk enhancers to further refine our risk assessment, but I think that there's things, I was surprised with the Prevent risk score. I thought that they were going to bring in or introduce sex-specific risk factors in some way, shape, or form, because we certainly know that people who have sex-specific risk factors, for women specifically, that we're not identifying them using these risk calculators. These risk calculators are heavily driven by age, especially for young women. And so you can almost guess every time we've been using the Prevent, and it seems to me almost identical in terms of my criticism for young people, it really doesn't help me identify them. They all appear as low risk. Well, what are some of the things we need to think about? We need to think about, of course, the fact that women can get pregnant, and pregnancy is a risk factor for cardiovascular disease, both acutely and long-term. So acutely, we know in the United States that pregnancy, mortality is on the rise, and we've continued to be concerned about this. It certainly has racial inequities, with Black women being specifically disproportionately affected. But the consequences of pregnancy do tend to be cardiovascular. The majority of the causes of death are cardiovascular, and that's why it's our business. That's why I think as cardiologists we need to be really involved in the care and the management of women. We know that many of the causes of maternal mortality are preventable. We review in the state of California, we review every woman who dies. We try to find out previous medical records. Did they present? Was there a sign that we could have prevented this death? And so you can see that about 70% of the deaths related to cardiovascular disease are identified as preventable, and whether that's while they're pregnant, within 42 days, or out to 1 year, because all that data is considered maternal mortality. So cardiologists need to be involved in that care. Traditionally, we really haven't been. I mean, now increasingly with women's heart centers and cardio-obstetric focuses, we're getting more involved in that care. We've written a number of papers to really help people identify people with the red flags of both symptoms, the red flags of signs that we should be aware of, and when they should call cardiology. So not just calling, when they should evaluate them, but also when they should be consulting, not just with maternal fetal medicine, but also cardiology, if cardiologists are available who specifically focus on cardio-obstetrics. I think that this is our way to at least reduce that acute mortality. It's changed. Pregnancy has changed. Who's getting pregnant has changed. I think that that's an important thing to understand that there's more cardiometabolic disorders in young people getting pregnant. Maternal age, of course, has increased as well. And also pregnancy in women who already have, cardiovascular diseases happening, as well as congenital heart disease. We're making people live longer, and they want to reproduce and they want to have children. So that's another group of patients that we need to be ready to take care of. And that's why we're seeing more mortality, but we need to really have more preventative efforts and more pregnancy heart teams established around the country with standardized protocols, because I think if you have protocols, ERs tend to follow those. Or, they'll call us when we say you have to call. And so I think that, again, even our obstetricians, if they know we want to be called, they're more likely to call us. Otherwise, they've been managing this sort of in isolation. But of course, pregnancy is also nature's free stress test, right? There's that acute events, but there's also the long-term events. It identifies people who have adverse pregnancy outcomes. It really tells us who might develop heart disease still at a young age. So we have now a significant body of data showing particularly hypertension during pregnancy, not just preeclampsia, but any gestational hypertension puts people at a higher risk, not just for hypertension and also diabetes, interestingly, but also all forms of cardiovascular disease, including heart failure. Gestational diabetes puts patients at a higher risk of cardiac disease. Preterm birth, small for gestational age, these are the things that we should be asking about for younger people if we're working on prevention, because 80% of women bear at least one child in the United States, and adverse pregnancy outcomes actually occur in 10 to 20% of pregnancies. So these aren't rare. These are really, common risk factors that we should be asking about. The actual mechanism of how this affects, why this causes cardiovascular disease, how they work, isn't fully known. Certainly for hypertension during pregnancy, particularly preeclampsia, there's definitely evidence of placental abnormalities and vascular changes that are probably triggered or maybe underlying already occurring at that time, but get pronounced during pregnancy. That may be part of it, but we don't always understand the other adverse pregnancy outcomes yet. But the important point is when we realize that they've had any of these adverse pregnancy outcomes, at least we can work better in our preventative efforts so that we can identify them and be more proactive about preventing cardiovascular disease in the future, because we're not talking long-term, we're not talking about when they're 70 or 80. We're talking about in the next decade that they are at a higher risk. So a young woman who gives birth 10 years later, she's still a young woman. So these are young people that we want to focus on. So with the ACOG group, the American College of Obstetrics and Gynecology, I was fortunate enough to be asked as the cardiologist to write about the fourth trimester. We actually coined the term, the fourth trimester, and we meant the entire period after pregnancy, meaning what are the things that we should be really focused on women after they deliver the baby, because the obstetrics care ends at that point, right? But we really need more than just that 6-week postpartum visit. We need to be talking to people about all these other things that have occurred. What should we counsel them on? What should we be treating? How should we longitudinally be focused on their health? Part of it being their cardiovascular health. So some of these things are not just cardiology, but there was a heavy focus on cardiology just because they invited a cardiologist to the table. And I will say that we work with our obstetrician colleagues now incredibly closely as a result of them being very much on board with the idea that we need partners in care. And so when I see patients, particularly because I see mostly women, our focus is across the lifespan. And depending on who you meet and when you meet them, asking about specific risk factors in addition to our traditional risk factors is important, because there's many things that we need to consider that put women at risk. And so asking about reproductive issues that we talked about, asking about PCOS, asking about birth control use, particularly in people who smoke, that puts them at a higher risk. Age of menarche also is both late and early increases the risk of cardiovascular disease. For our older women, again, After menopause, of course, many of the risk factors increase. So we need to be really addressing the whole lifespan of where we meet the women, how do we do better risk assessment. Now, part of the reason that we don't know a lot about women is related to the fact that we haven't really done a great job at getting women into clinical trials. And I love this cartoon. You know, we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anyone. And I feel like that's so true for cardiovascular disease because we really did exclude women from trials and we're playing catch up. So this is an old editorial from 1991. This was written by Dr. Bernadine Healy. Some of you might remember her, but Bernadine Healy was a cardiologist, a very famous cardiologist, and the first woman to lead the NIH. And she wrote this editorial using the story of Yentl. So if you don't know the story of Yentl, Yentl was a woman who wanted to study the Talmud, and she couldn't in the 19th century because she was a woman. So she disguised herself as a man to be taken seriously, and that's the way that she could. And so she used that story. And again, it's a written story. It's also a movie with Barbara Streisand. But it was really saying, you know, do women have to present exactly like men to be taken seriously? Is that the only way? And where are the women in the trials? Or the reason they're not in the trials is because they didn't present exactly like men. And so she was the woman that actually pushed to get funding for the Women's Health Initiative, pushed to get the inclusion of women into trials, and established the Office of Women's Health Research at the NIH. So there's many great things Dr. Healy did, but again, unfortunately, we're still, you know, this idea that Yentl syndrome would disappear and be the history of curiosity of times gone by, that still has not been achieved. If we look at inclusion of women in cardiovascular trials, you can see here that if you look at the disease type, you know, really only pulmonary hypertension. That's the only disease state where we over-enroll women. Everything else, we under-enroll women, and particularly heart failure and coronary artery disease tend to be the areas, even though they're the most common diseases in both men and women, that we under-enroll women. Intervention type, doesn't matter if it's drug, device, lifestyle, procedure, we don't enroll enough women. Doesn't matter where it's done in the world. Globally, we under-enroll women. Doesn't matter if it's a small study or a large study, we don't get enough women. We're getting better at getting women under the age of 55 into trial, so that's good news. But again, since cardiovascular disease tends to affect people as they're older, we need to do better at getting people over the age of 55 into our trials. And interestingly, sponsor type really doesn't matter, although if you see the lower bars in sponsor type, the biggest thing to take away is whenever government funding is involved, there's actually less women enrolled in trials. So this isn't to bang on the NIH, this is globally, but anytime government funding of trials, nobody's held accountable. 52% of their population seems to be less important. And then don't even get me going about pregnant women. They're relatively unstudied, and that's why we don't know a lot about how we treat women when they're pregnant. You know, I'd just like to take us back to medical school, though, because when I was in medical school, I certainly learned a lot about drugs and the way that they, you know, how they are absorbed and distributed and metabolized. And we learned that for women versus men, there would be a difference. And certainly for pregnancy, they would be different. And yet when we study drugs, we often don't have representation of women, let alone pregnant women, to really say that do these drugs work as effectively? What are the differences between them? And when you look, like just using hypertension as an example, because we all deal with hypertension, think about diuretics. Diuretics commonly used to control hypertension. Did we know that the plasma concentrations were higher in women compared with men, about 30 to 40% higher? So it shouldn't be surprising that when we use diuretics, there's more electrolyte imbalance in women. And then there's more arrhythmic risk for women. Beta blockers, similarly, higher plasma concentrations. Actually, they increase even further if a woman's on oral contraceptives. So heart rate reduces more in women, blood pressure reduces more in women at the same doses. And I only use this as an example. I'm not going to go through every cardiac drug, but my only point is we need to be studying both men and women when we're introducing new drugs to our population, because this is how we will learn about the differences and understand it. We're often learning about drugs later, not they don't come out with saying this is the way that women are going to react. But part of the reason is that we just haven't enrolled women in trials. And why did that happen? Just to give you a little bit of history, I mean, does anyone remember thalidomide? So thalidomide was introduced in Europe without really any studies. It was for morning sickness. And unfortunately, it had very adverse consequences to the offspring of the women that used it. So almost immediately, the FDA in the 70s said, you know what, women of childbearing ages, childbearing potential, they cannot be in phase 1 and phase 2 trials. And that was the beginning of exclusion, really, of women into trials. In the 1980s, the NIH did try to say that women should be included in studies. And then it was in the 1990s when Bernadine Healy was there that the Office of Women's Health Research was established. Congress actually mandated the inclusion of women in trials, but didn't really say how that was going to happen. And the FDA finally removed the restrictions of women participation, of just by being just childbearing age, that you could be in trials. In the 2000s, though, they did recognize we're not learning anything about pregnancy. Let's have pregnancy registries. So the FDA started the pregnancy registries. In the 2010 decade, the FDA noted that for medical devices, there was often no reporting of women, and they didn't know if there was women even in some of the things that came up to the FDA, and it wasn't actually necessary to come to the FDA and include any women. It wasn't until 2016, actually, that the NIH mandated that the preclinical studies, the cell studies, the animal studies, actually include both sexes. I don't know why, but even mice studies, for example, were all male mice. Maybe they were cheaper. I don't know, or maybe the female mice bit, I don't know, but maybe the pesky problem of female mice getting pregnant was annoying to them. You know, there's a lot of reasons but now it's mandated. So if you get NIH funding, you have to have both cell lines, both animal lines. So in the 2022, actually, the FDA finally said that you have to include sex and gender reporting for devices. That's a big move, and that just happened. The Institute of Medicine also in end of 22 also put out a statement about improving representation in cardiovascular trials and emphasized the need for inclusion of women and people of diverse backgrounds. So just to give you historical perspective, we're just really getting to the point where we'll have more women in our trials. You even look at the FDA trials of drugs, and cardiology is this light yellow line. I don't know if you can see that where my arrow is, but that's cardiovascular drugs that went up to the FDA. You can see that we're doing less well than all other disease states. So it's something about cardiology. You know, our obesity trials are an exception in the sense that the obesity trials did include a lot of women. But then when they did the trials with cardiovascular disease and obesity, we under-enroll women again. So we've got to be more cognizant of this. So how do we improve the care of women across our nation? Well, I already told you, we need more diversity in our trials. That's certainly one area we need to focus on. We need, though, to apply our guidelines currently equally. If we just did that, we would save lives. We need to talk about bias and where there's bias, identify the bias, and try to reduce gender bias in care, since that's driving a lot of these differences. I think focused women's heart centers will improve the care, and I know you all have a women's heart center, and I think that's going to help. When you have an expert in your midst, they will help everybody else be better in the care of women. And of course, we need to follow our own metrics. We need to follow them globally, nationally, everywhere, because the more we know about where the gaps are, the better we'll get at taking care of our women. So I hope I've shown you that women remain under-recognized, underdiagnosed, undertreated, and understudied in cardiovascular disease. Women continue to receive less guideline-directed medical therapies. So if that's the only thing we do, we're going to save more lives. If that's the only takeaway you get from me today. I think we need to focus on our electronic health record to empower us rather than being a billing mechanism. Really, can we use it to really alert us that somebody isn't on treatment or needs treatment and make people really improve the care of women? We need to think about AI to really enable things that maybe that can help us as well. How can that help us remove the bias? And I think we, of course, need women to be studied because when we look for sex differences, often they do exist. So I think we can go there. I think it's wonderful that our government right now is, putting women's health on the map. Literally, they came to us, they started this discussion about women's health and where we need to go. And they did cardiovascular disease with us at Cedars-Sinai. As you can see, the First Lady spent the day with us learning about heart disease and then went across the country and learned about different conditions, and they've now committed over $100 million. And so I'd just like to end and show you my team that I work with every day at our Women's Heart Center. And I want to also thank you all for inviting me for this important lecture.
Thank you. That was fantastic and humbling. We have some time for questions. Any questions? Nick?
As much as I hate to ask this question, is there data on difference in outcomes and application of GDMT between male and female physicians?
Yes. Well, there is some data, and of course it's fraught with bias, but every time we look at it, and there's just a study that came out recently, but every time they do look, it does look that female practitioners are better than male practitioners at following guidelines, first and foremost. And then when we look at the care of female patients, it does tend to be improved when there is female practitioners, but there's not a difference of female practitioners taking care of men, meaning they take care of them equally. Where male practitioners do better is when they're surrounded by more female colleagues. So in emergency rooms, for example, emergency room physicians who have a greater proportion of women physicians, the male physicians tend to actually take better care of acute chest pain, for example, or as one place where we have some data where there's some influence of having female physicians. Now, of course, some of this is hard because when you look at records of where people are male and female practitioners, it might be like the initial person. And so if you look at ER, there's more than one doctor taking care of a patient usually in an ER. And same on the floors, right? It's not just one person often. So I do think there's some limitations, but I think, yes, you should hire more female physicians.
Jake?
Thanks for that great talk. Having worked in the cath lab for the last 25 years, it sure seems like there's a lot more Takotsubos now than there was then. And if that is true, why?
Yeah, it's interesting. I remember when I was training and we learned about Takotsubos and it was supposed to be this rare thing. And then once you learn about it, you're like, is that Takotsubos? Is that Takotsubos? We started recognizing it more and more. And so I don't know if it's like our heightened recognition that we now see it, know it, and realize it's there, or is it really happening more? And I honestly don't have an answer for you. I think that this is why some of the Takotsubo registries might help us, but I don't know why we're seeing it more. It certainly is not rare, right? I think that we would all say that we see it quite a bit.
Hi, Martha. Just to follow up on that, do you think, so there was that really nice abstract that was at ACC looking at our genetic predisposition to have more anxiety and depression and our increased risk of cardiovascular events. Do you think that part of the Takotsubos we're seeing, the SCAD, perhaps even the more ANOCA we're seeing, is due to a difference in our genetic predisposition to things like tendencies towards anxiety and depression.
Yeah, I mean, it very well could be. We certainly know that there's a stronger, right, neurologic heart connection for women because these things certainly are disproportionately affecting women. And so I think we need more work in that area, but that very well could be genetically, genetic based of being XX versus being XY and how our response to stress and anxiety can be. I don't think men necessarily have less stress or even less anxiety, but it's how it's pronounced and how it physiologically affects us. So I think that it's a really interesting area. I think again, we're saying it's not rare. We're saying especially for postmenopausal women, it's about at least 10% of the acute MIs that we're seeing. And I hope that now people will be able to get some answers for what do we do and maybe hopefully how we can prevent it altogether.
Do you have any online questions, John?
None thus far.
All right, excellent. Well, thank you so much. This is fantastic. Thanks for being here.
Thank you.
Have a great day, everyone.